presenting a new series Medically Verbal where we'll solve case history in just a couple of minutes.
Disclaimer. This video is intended strictly for educational and informational purposes only. It does not constitute medical advice, diagnosis, treatment, or professional consultation. The content is based on simulated or anonymized cases and does not refer to any real individual. Always seek the guidance of a licensed healthcare professional for any personal medical concerns. The creator of this content assumed no liability for the use or misuse of the information presented. Now that we're clear, let's walk through today's case step by step.
A 17-year-old hostel student brought to the ER by his roommate. The chief complaint? High-grade fever, persistent headache, and by morning, he couldn't even recognize where he was. The roommate noted that he'd vomited twice last night and had been extremely irritable and photophobic throughout the evening. When I approached him, he appeared disoriented, murmuring incoherently. His neck seemed stiff. I gently flexed it forward, and he winced in pain. Koenig's and Brzezinski's were both positive. His vitals were concerning: 102 degrees Fahrenheit fever, heart rate of 110, and a respiratory rate of 22. Blood pressure was stable at 110/70. GCS hovered around December 15. No seizures yet, but he was definitely altered. There were no significant past illnesses or surgeries. No known allergies or drug use. He doesn't drink, smoke, or do drugs. But he did recently travel home to Bihar, an area with ongoing monsoon flooding and reported outbreaks. At this point, bacterial meningitis jumped to the top of my list. The plan was swift: full CBC, CRP, and blood cultures to look for systemic infection. But most importantly, a lumbar puncture. Of course, only after a CT brain, to ensure there was no raised intracranial pressure that could worsen with LP. Why these tests? The CBC and CRP help detect the extent of inflammation and leukocytosis, classic bacterial red flags. The CT scan checks for mass effect or edema, crucial to avoid herniation. Then, the CSF analyses are key. If it's turbid, with high protein, low glucose, and neutrophilic predominance, that's our textbook meningitis. And that's exactly what we found. CSF came back cloudy, with 2,200 cells per mm superscript 3, mostly neutrophils. Protein was up, glucose was down. Gram stain showed gram-positive diplococci, likely pneumococcus. We immediately started for ceftriaxone and vancomycin, but not before giving dexamethasone. That's important to reduce the inflammation caused by bacterial lysis. He was also put on maintenance fluids and antipyretics. His blood cultures later confirmed Streptococcus pneumoniae. We ruled out TB meningitis, no subacute timeline, no basal enhancement on imaging, and viral causes were less likely due to the neutrophilic CSF and the severity of symptoms. The final diagnosis? Acute bacterial meningitis due to Streptococcus pneumoniae. We monitored him closely for seizures or worsening GCS, and involved neurology when needed. Within 72 hours, he began responding to questions, and we adjusted antibiotics per sensitivity. If not treated early, this could have ended in permanent hearing loss or hydrocephalus. But with timely intervention, he's going to be okay.
Directions or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.